Good morning. I am Thalia Harmony, and I want to present you the symposium on cognitive activity in infants at risk of brain damage. The aim of the present symposium is to provide an overview of the neurocognitive development of infants at risk of brain damage, focusing on structural and functional development during the first year of life. It is a topic to emphasize the public health problem that constitutes these infants and the need to design early detection and treatments to promote normal neurodevelopment. Public will enjoy the diversity of talks at present. For the presentation, the first presentation will be by Dr. Serena Council, later on Dr. Monica Carlier, afterwards Anne Gallagher, and to end myself. Thank you very much. Please, Serena, begin your presentation.
Thank you, Dr. Harmony, for that introduction. I'm going to share my screen now. And the title of my talk is Neuroimaging and Cognition in at-risk infants. I'm presenting this work on behalf of my colleagues. So what I'd like to do is to just initially give a recap of quantitative MRI and neurodevelopmental outcome studies, and I shall do that very briefly. And then I'd like to divide the talk into first a section on multimodal imaging and to highlight data-driven approaches that may help us understand the relationship between brain structure and later outcome. And then for the second half of the talk, I'd like to address the issue of heterogeneity in our study cohorts and to show how we can actually address that in two different cohorts with examples from a preterm infants and from infants with congenital heart disease. So just to recap, things that I'm sure you already know, but there have been many studies looking at quantitative MRI in the neonatal period and later outcome. For example, studies looking at cortical folding and cognition, regional brain volumes, and specific structural and functional relationships. For example, the neonatal arcuate fasciculates and language development at 2 years. Many studies have also looked at thalamocortical connectivity and later outcome. And here we can see examples of using diffusion MRI and using resting state functional MRI. However, all of these studies have used only one imaging modality. And we always acquire a number of different imaging modalities when we undertake a neuroimaging study. And each of these modalities gives us some rich information. But by selecting one a priori, we may be missing information that can be provided by a combination of imaging modalities. And that's what I'd like to talk about now. This is a large study done by Gareth Ball when he was a postdoc in our group, which used different images. Here we have volumetrics, T2, and diffusion MRI to give us fractional anisotropy and mean diffusivity. We also have a lot of clinical information about the mum and the antenatal period, about the baby, and about the context of the family. So by using a data-driven approach, we can actually look at independent components from the images, using all of the images, and we can use principal component analysis of the clinical data. Then we can actually search for correlations between the multimodal neuroimaging and the clinical information using canonical correlation analysis. So let me show you what the results were. So we actually got 4 different patterns or modes of imaging markers from this study. And the first is the one I've shown here on the top left-hand corner, which is an imaging marker that comprised of increased volume, altered T2 intensity, in some regions decreased T2 and in some regions increased T2 intensity, reduced mean diffusivity in central grey matter, and elevated fractional anisotropy in the white matter. And this imaging pattern was associated strongly with age at scan and very slightly associated or negatively associated with the days on CPAP. So we've got a marker that comprises increased volume, decreased mean diffusivity, increased anisotropy, correlating with age at scan. These are markers that we would expect to be related with maturity or increasing maturity. However, I'd like to talk now about the second imaging marker that we observed. This imaging marker was associated with increased brain volume, again, altered T2 signal intensity, decreased mean diffusivity in central grey matter, and increased white matter anisotropy. Now, this imaging marker was associated positively with birth weight and gestational age at birth, negatively with the days on CPAP, TPN, requirement for surfactant, and days on ventilation. So essentially, I think this imaging marker is associated with maturity, older age at birth, and negatively associated with infant sickness in the neonatal period. But importantly, this multimodal imaging marker was also associated with cognitive and motor outcome at 2 years. So by using this data-driven approach and by combining a number of different imaging modalities, we can find novel patterns of imaging features that are important both for clinical features and for neurodevelopmental outcome in early childhood. So I suggest that these kind of multimodal imaging approaches may actually offer us much richer information than can be obtained from individual modalities alone. And what I'd like to do now is to talk about how we can address heterogeneity in our neuroimaging studies, or at least one approach to addressing heterogeneity. So why would I want to do that? Well, if we think of this, most neuroimaging studies and most studies that we do, we have two groups. We have the controls, shown here in blue, and then we have our cases, our at-risk infants in this case, shown here in red. And we presume that these two groups are distinct. They come from two distinct groups. But that is often not the case. It may be that our at-risk group, our patients, actually have different pathology and actually don't comprise of one single group. And actually, if you think of congenital heart disease, and we'll hear more about that later, this is very definitely the case. It may be that our cases are nested within the controls, maybe one side of those controls. And it may well be that our cases are actually quite different from each other because perhaps due to multiple morbidities. But our traditional control case design doesn't address this issue. So how can we do that? How can we look at brain development on an individual basis? Well, I'm sure this graph is something that you're all familiar with. It's a head circumference chart for boys. And we're used to looking at Z-scores and centiles for both weight, for weight during growth, and for head circumference. Well, if we think of this concept, we can actually apply a similar concept to neuroimaging parameters. And we can take any imaging phenotype that we're interested in. It could be brain volume, it could be diffusion MRI, it could be a tract. But if we have a sufficiently large normative sample, we can generate the normative curve for that imaging phenotype, just as we have done for head circumference. If we generate the normative curve, we can actually look at deviations from the mean. And in this case, I'm going to talk about atypicality indices, representing how far an individual is from the mean. If this is our normative data, we can take an individual from our patient population, be that a preterm infant or an infant with congenital heart disease, and we can actually see where that individual lies on the curve with some measure of predictive confidence. So let me show you a couple of examples of using this normative modeling approach to assessing individual brain development. So this work was done by Rale Dimitrova, who's a postdoc in our group, and she looked at normative development in using diffusion MRI on a voxel-wise basis. And we expect anisotropy to increase and mean diffusivity to decrease with maturation. And I think these infants are ranging from 37 to 43 weeks here. She had a large sample size of around 300 healthy infants taken from the Developing Human Connect Home project. And on a voxel-wise basis, she looked at the FA and mean diffusivities across these infants. And I've just picked 3 regions here, just as an example for anisotropy and mean diffusivity. Here in the cerebellum, you can see anisotropy increasing, and this is the mean, the black line. And for the individual cases, you can see how they relate to the mean. And the same for the gray matter. And of course, mean diffusivity, we'd expect to decrease with maturation as it does here. So this is our healthy sample of 280 healthy infants who had normal developmental outcome at 18 months. What about now if we look to see the preterm individuals? Well, here we are. These are 4 individuals. This is a baby who was born very close to term. And the orange shows the atypicality index, so the deviation from the mean, in this case, an elevated mean diffusivity. In this infant in the top left, who was born almost term, you can see there are very few regions where there's a slight increase in mean diffusivity. But in the other 3 panels, we have 3 preterm infants, 23, 24, and 33 weeks. And all the regions that are in orange show where there's a voxel-wise abnormality index or atypicality index, representing an elevated mean diffusivity in that area. And I think what's quite striking is that the areas don't coincide with these babies. Each baby has a different pattern of abnormality from the other one, highlighting the difficulties of doing group comparisons. But are these atypicality indices important? Do they correlate with outcome? And this session's all about cognitive outcome. Well, yes, they do. So here's the relationship between the atypicality index and cognitive score for the fractional anisotropy and for mean diffusivity. And the atypicality index, the deviation from mean in anisotropy was related to cognitive score and language score. And this remained significant even if we took out this outlier. And we can see actually those voxels in that individual where they had a high atypicality index. For the mean diffusivity, a higher mean diffusivity, so that's a positive atypicality index, was associated with cognitive score. And these are 2 different individuals. You can see on the bottom right here. And we can see that whilst they both had a high atypicality index, the regions that were atypical were very different, one in the cerebellum and one in the centrum semiovale. But by actually assessing the brain in terms of this atypicality index, it doesn't matter that the regions are different. What this shows us that actually abnormal values in mean diffusivity are associated with poorer cognition at 2. I know Dr. Gallagher is going to talk about congenital heart disease in her talk, so I'm not going to say a great deal about the neurodevelopmental sequelae of congenital heart disease. I just want to show an example of where we can use this normative modeling approach to assess the relationship between early imaging and childhood outcome in congenital heart disease. So a number of studies have shown differences in brain development in infants with congenital heart disease compared to healthy controls. And that includes cortical folding, white matter microstructure, and cortical microstructure. But one thing that comes up repeatedly is smaller brain volumes in individuals with congenital heart disease. This was shown originally by this nice fetal work by Catherine Limperopoulos, also shown in adolescents, this, for example, this study by von Rijn. We've shown it in the neonatal period, where we used tensor-based morphometry to show smaller deep gray nuclei in CHD infants, shown here in blue, and larger CSF spaces, shown in orange. But again, this is a group comparison. We're also very aware now of the importance of cerebral oxygen delivery in brain development in congenital heart disease. And this elegant work by Mike Seed's group showed that in utero, reduced cerebral oxygen delivery is associated with smaller brain volumes. So taking these things together, we asked the question, is impaired neonatal volumetric brain development associated with reduced neonatal cerebral oxygen delivery and neurodevelopmental impairment in early childhood in infants with congenital heart disease? And this work is work by Alexandra Bonthron, who's a postdoc in our group. So Alexandra undertook some image segmentation. We have measures for CSF, cortical gray, white matter, and cerebellum. And the deep gray nuclei are divided into the lentiform in yellow here, in red here, the caudate in yellow, and the thalami in blue. So Alexandra used this normative modeling approach. She had around 250 healthy control infants. And the gray shows the total tissue volume for the healthy controls. And the black line is the mean value for the healthy control infants. The blue and the green show our congenital heart disease population. And we can very clearly see that most of the infants with congenital heart disease are below the mean. In fact, some are 2 and 3 standard deviations, or they have an atypicality of 2 or 3 compared to the healthy controls. To measure cerebral oxygen delivery, we looked at the saturation, hemoglobin, and cerebral blood flow, and we calculated cerebral blood flow using phase contrast angiography as shown here. So here are our results for the thalamus bilaterally and the caudate, and we've divided them into male and female. We can see again the gray is the healthy control population and the blue are our CHD sample. And as we saw in the total brain volume, most of the infants with congenital heart disease are below the mean. And some are actually quite remarkably below the mean here in the caudate nucleus, for example. We found that cerebral oxygen delivery was correlated with the atypicality indices from all brain tissues. So that's lower cerebral oxygen delivery is associated with a greater negative atypicality index. But what about the relationship between the atypicality index and brain and Bailey scores? Well, the cognitive composite score for this group for our CHD infants was 93 and motor was 94. And as you know, we'd expect the mean of a population to be 100. So these are below the mean of the normal population. We found that the Bailey scores were associated with the atypicality index for the thalamus and the caudate bilaterally and for the left lentiform. However, cerebral oxygen delivery did not correlate with cognitive or motor scores. So that leads us to the question then, is cerebral oxygen delivery not important for later cognition? Well, to answer that question, we undertook causal mediation analysis, and causal mediation actually assesses the mechanism relating to variables, in this case, cerebral oxygen delivery and the composite and the deep gray nuclei. And we found that lower cerebral oxygen delivery was associated with impaired cognitive development through the mediating effect of the atypicality index of the thalamus and the caudate. So this mediation analysis suggests that the etiology of poor cognition in infants with congenital heart disease may encompass lower cerebral oxygen delivery, leading to impaired grey matter growth. So to finish, I think we're aware that there are now a large number of studies showing a relationship between quantitative MRI in the neonatal period and later outcome. However, most of these studies are unimodal and don't take advantage of the multimodal imaging that we all acquire. And I think one thing to bear in mind is that most studies assess outcome in early childhood. So as a community, we need to be following our children up into later childhood and beyond to assess the relationship between early brain structure and outcome. I think normative modeling offers the opportunity to move away from case control studies and to assess brain development on an individual basis. But I am aware that the disadvantage of that approach is that we require a large sample of healthy neonates, which aren't available in many centers. So to take on that last point about the large sample of healthy neonates, I think we need as a community to develop approaches that enable multi-center neuroimaging studies so that we can actually share our data and work together to address the issues of poor cognition in at-risk infants. I'd like to finish by thanking the large team of people whose work I've shown today, and thank you for your attention. Thank you.
Thank you very much, Serena. Someone of the other participants want to make some comment?
Maybe I can start. Thank you very much. It was extremely interesting. And it's very elegant way to look at the data as in a multimodal way. You're right, it's not always possible due to smaller sample size, but it's really beautiful. I have a question about, it's more a clinical question. You know, when I think it can have a really big clinical impact to identify such markers or very early into in the development. And I was wondering, you know, you show a graph. I don't know if I have the slide, or you were looking at, there were 4 graphs, and there was a correlation between the atypicality markers and cognitive outcome and the outcomes. And I was wondering, first, at what age were the outcomes?
So the outcomes in the diffusion MR study in the preterm infants were at 24 months. Sorry, okay. Yes.
Wow, okay. Which is fantastic, because we know that it's pretty it's more predictive than the 12th month at the with the Bailey, so it's good. And it's and I was wondering, you know, there were these 2 individuals that were really atypical markers. So would it be would have been possible to identify them as very high risk because they had neurological or behavioral, or did they have any markers other than this being that could have identified them as early?
That's a really good question. So what you're actually saying is we could actually use the atypicality index to go back and see what was important in those children, and yes. So I can't answer that question for those individuals. I know we accounted for gestational age at birth, but in those individuals, the atypicality, or the maximum atypicality, was around the cerebellum in one case and around the centrum semiovale in another case, so quite different places. But if there was something particular in their clinical course that for both of them, or at least they were at high risk, maybe at prolonged ventilation, for example, then we could certainly go back and have a look at that, yes. I think in the first study I showed, we took into account all the clinical features in that multimodal imaging study. In the second study, looking at the atypicality, we included sex and gestation at birth and age at scan, but not all of the other clinical variables that we know are important for later cognition.
And there are so many, so it's, but it could be interesting to look at this. So for centers who don't have access to imaging, and also to better understand what's going on.
Yes, in those individuals, I agree.
But it's really interesting presentation. Thank you very much.
Thank you, Anne. Thank you.
Well, I want to say, Serena, that this multimodal research, I think I will begin to this because I have a large amount of that. And I think it's very interesting. I have already made a database of almost 1,000 children, so I hope I will be able to do it. Thank you very much for your presentation.
Wonderful. Thank you, Dr. Harmony.
And now I give the word to Dr. Maria Elizabeth Monica Carlier.
Okay. Today I am going to talk about processing of auditory stimuli in infants at risk of brain damage in the first year of life. Risk factors for brain damage negatively impact neurodevelopment in different areas such as motor development, mental, social, and cognitive development. We have been studied language development in preterm infants, and we have found that this population have more probability of presenting central auditory limitations than infants. In this presentation, I will present two studies in this direction. In the first study, we explored the perception of repeated syllables in preterm infants. We studied two groups, 13 term infants and 29 preterm infants. Before the study, infants received various clinical tests to see if they met the inclusionary criteria. And the inclusionary criteria was as follows: clinical examination by a pediatric neurologist for the term infants was normal, neurological signs, MRI examination normal, clinical EEG normal, vision and audition were normal. For the preterm infants, clinical examination by a pediatric neurologist presents mild to moderate abnormal neurological signs. MRI presents dilated ventricles. EEG was normal, vision and audition were normal too. We examined the infants using two tests, the Spanish MacArthur-based Communicative Development Inventory and the electrophysiological tests. We record the infants listening to repeated syllables. The behavioral test divided the preterm infants into two groups, one who scored high and the other who scored low. A high score was considered about the 60th percentile. All infants scored normal in the behavioral test. We measured the repetition effect by examining the infant's oscillatory brain activity during processing of repeated syllables. The EEG recordings were performed by placing an infant's electrocap fitted with electrodes of the 1020 International System. We analyzed the brain's response using time frequency analysis of the EEG, and we measured the repetition effect as a reduced theta power from the first to the second syllable in the fourth syllable train in the frontocentral area. Infants' brain response can be observed in these time frequency maps. Let's read the maps. On the x-axis, we have time, and on the y-axis, we have the frequency. The color code indicates the amount of theta power at a given time and frequency. Increasing power of the pre-stimulus was coded in increasingly warming colors. The dotted lines, I don't know if you can see the dotted dotted lines represents the onset of each syllable in the train. We found the repetition effect reduced theta power from the first to the second syllable, as you can see here, more red color in response to the first syllable, and then the increases of power reduced in the second, third, and fourth syllable. So we found the repetition effect in the term and in the highest score preterm infants. We found the pattern we defined before, but we did not find the repetition effect in the lowest score preterm infants. A typical processing of repeated syllables was found in this group. This atypical processing of repeated syllables can be related to alterations in auditory sensory memory or limitation in the processing speed. These results are in line with other studies we have developed in our lab, in particular the Avecilla Ramirez et al., and where she found a typical processing of repeated syllables and tones in infants with periventricular leukomalacia. Then we conducted a second study, and in the second study, we explored auditory sensory memory in infants. And before going ahead, let's define auditory sensory memory. Auditory sensory memory enables listeners to integrate incoming acoustic information with a stored representation of preceding auditory events. Auditory sensory memory is responsible for the perceptual organization of sounds that allows the interpretation of the auditory environment. We explored the representation of sounds during the processing of a train of 4 syllables in where the first 3 syllables are repeated and the last one is different. Infants can predict the last syllable. The processing of this train of syllables can involve 2 types of sound organization in memory. One in which infants hold the sequence as an auditory unit, and a second in which they retain each syllable as an auditory unit. Since infants can predict the last syllable in the train, we expect that the infants represent the sound as the complete sequence. The auditory unit will be a complete sequence. So we conducted a study. We studied 2 groups, 14 term infants, 14 preterm infants at 4 months, and 11 and 13 at 8 months, respectively. We lost some children in the process. The inclusionary criteria was as in the previous study. For the term infants, clinical examination by a pediatric neurologist was normal, and for the preterm infants, presents mild to moderate abnormal neurological signs. MRI normal for term infants, and MRI for preterm infants presents dilated ventricles. Clinical EEG was normal. Vision and audition were normal in both groups. Infants were examined using 2 tests: the electrophysiological test during processing of a train of syllable like that at 4 and 8 months, and a behavioral test at 12 months, and we used the Spanish MacArthur-Bates Communicative Development Inventory. We follow the same procedures for recording the EEG as in the previous study. We use the electrocap fitted with the electrodes with the 1020 international system. We analyze the infant's brain response to the time frequency analysis of the EEG. And we measure the organization of sound in auditory sensory memory by examining the repetition effect. The repetition effect was measured in this case as a reduced theta powers from the first to the second, third, and fourth syllable. If the repetition effect is present, we assume that the infant represents the stimuli or the complete train as an auditory unit. If it's not present, the infant retains each syllable as an auditory unit. The brain The infant's brain response can be observed in the following time frequency maps. As mentioned before, on the x-axis, we have time. On the y-axis, we have the frequency. The dotted lines represents the onset of each syllable in the train, and the theta power in red represents increments of power with respect to the pre-stimulus. The repetition effect was present in the term group at 8 months. As you can see, we can observe reduction of theta power from the first to the second term in 4 syllables. So this response leads us to think that the term infants hold the sequence as an auditory unit. They recognize the pattern. We did not find the repetition effect in the preterm infants. Then we assume that the preterm infants hold each syllable as an auditory unit. They did not recognize the pattern. We did not find the repetition effect in any group at 4 months. The response at 4 months for the term infants wasn't clear. We couldn't find the pattern we defined before as repetition effect. And we follow up with these two groups at 12 months, and we found that all infants scored in normal ranges in the Spanish MacArthur-based communicative development inventories. However, term infants scored higher than preterm infants. The question we raise is, why does the behavioral test shows typical development and the electrophysiological test show cognitive limitations? This may be because the behavioral test is not measuring the cognitive abilities, but general communication skills, or maybe because the behavioral tests do not discriminate these infants well at very early ages. So we have found in these two studies that infants at risk of brain damage may present cognitive limitations like limitations in the processing speed, or limitation or alteration in the auditory sensory memory. And we know that these cognitive limitations are very critical in the first year of life, because this limitation may cause a representation of a noisy or degraded phoneme repertoire and of a defective processor in the brain that limits memory operation in the use of language. To conclude, I want to state that cognitive limitations can be challenging to detect at very early ages, but they may be present in infants at risk of brain damage. Therefore, we must prioritize early prevention programs in this population. We have developed some prevention programs that we use in our lab. One for stimulate early language. This program is based on teaching parents how to stimulate language in infants from 0 to 30 months. And we also have developed a program to stimulate and diagnose delays in selective attention in the first year of life. And this is all. To finish, I want to thank my colleagues at the Neurodevelopment Research Unit who have contributed enormously in this work. Thank you very much for having me.
Thank you, Monica. Does one of the other colleagues want to make some questions?
Can I ask a little one?
Yes, of course.
It was also super interesting, really. Thank you very much. And I was wondering, this cohort, for the last data you showed with the EEG that was able to discriminate between preterm and term babies, and then the MacArthur bait at 12 months, Was it at
Yes, at 12 months,
Yeah.
yes.
Are you expecting, will you follow them, or did you follow them to see if you can discriminate them for language difficulties or impairments later on in the development, or not yet?
Not yet, not yet. We're
You're
planning
still-
to do that, but not yet, because we lost some children in the process. But that is a good.
But
Good
yeah, I
question.
think I find it very, very interesting to see that you can clearly see differences at the EEG, the way that they process the
Yes.
like the pa 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 ta, or
Mhm.
and it's another very strong argument, as many others that we have, to show that EEG is a very powerful tool for early screening. And so I think if you can follow them and show that it could be another good argument to trying to have it systematically in all preterms. But I think you already do that in Mexico, no? The early screening with EEG.
The problem with the EEG is it's a very powerful tool, but we cannot diagnose a child in an individual way. The analysis you do is using a group of infants, because nowadays the EEG don't give you the power to diagnose a child just with one EEG that you perform. So that is the challenge. You need to find ways to diagnose this type of typical processing of language individually. We cannot do that right now. So the studies we have done are based on group analysis, and we have observed in our cohort of children at the Neurodevelopment Research Unit that behaviorally, at 2 or 4 years old, they present delays in speech delay. We have a group of late talkers, and we are working with these children to see how we can help these children early in life. That is the challenge.
Yeah, I totally understand. I have the same problem too with the small samples. We need the data, all data, like Serena had with the big samples, and she created the normative data. Yeah, hopefully we'll be there one day with the EEG.
Yes.
Yeah, one thing I can say is that the problem to follow up with the children we have in the unit, now it's a very big problem with the COVID pandemic, because with the COVID pandemic, we close the unit in order that the children and parents will not may have the virus. So now for us, it is very, very difficult to continue with the prognostic and the follow-up of all children. We are doing, but only from digital procedures, not with presential procedures. And this is really a great problem for us. Well, next speech is Anne Gallagher, that she will present her work.
Yeah, so yeah, longitudinal COVID has been really hard for longitudinal studies. Yeah, for us too. But thank you very much, Thalia, and thanks for organizing this this symposium. I'm really glad to participate. And also, I'd like to thank the IOP organizing committee. I can't wait till next year to see you all in person and to meet you in person. So, so in her talk, Dr. Gonçalves talked about, did a great recap about recent functional connectivity MRI studies in relation with later neurodevelopmental outcome, and showed really interesting structural connectivity and structural data, MRI data in infant born preterm, and also in infant with CHD, congenital heart disease. So I'm going to expand a bit on brain connectivity in children with congenital heart disease, talking about functional brain networks using functional near-infrared spectroscopy. Sorry about that. Okay, so let's start with some background on the congenital heart disease, which is the most common congenital anomalies affecting about 1% of all newborns. More than a quarter of these malformations are complex CHD that requires surgery during the first days of life or during the infancy. There have been tremendous medical and surgical advances that have led to greater long-term survival rate. So it's about 85% of children with CHD who will survive until adulthood. However, this significant increase of surviving rate comes with increase in neurodevelopmental comorbidities, with about 50% of children with congenital heart disease who develop impaired motor and cognitive functions. So we now know pretty well the developmental pattern of children with congenital heart disease. We know that many of them will have motor, language, and cognitive delays or impairments. Sorry about that. Okay, and when we look at the global intellectual functioning, we can see that most children are in the average, but slightly below, but remain in the average. But still, there are 15 to 42% of children who are below the average. There are 39 and 49% of children that have a gross and fine motor skills delay, respectively, and 12 to 40% with language impairments. Later on in their development, usually at school age, we can see some visual, spatial, attention, and executive deficits in these children. Of course, all these comorbidity have an impact on school achievement and lead to behavioral and psychosocial maladjustment. So many children will need some rehabilitation services, tutoring, and special education. And based on this very high rate of neurodevelopmental delays in children with CHD, the American Heart Association and the American Academic Pediatrics recommended early surveillance, systematic surveillance, and developmental assessment in all children born with complex CHD. For instance, in our hospital, at the St. Justin Hospital, we follow all children with CHD from 4 months of age, providing systematic assessment and individualized interventions. Language difficulties typically appear later, around 2 or 3 years of age, and cognitive deficits even later. So it would be greatly beneficial to have much earlier markers of developmental outcomes to provide early personalized intervention to children who are at higher risk for neurodevelopmental disabilities, as my colleagues showed in their the previous talks. Our group, we believe that brain networks development could constitute an effective marker to predict child neurodevelopment. So in our talk, Dr. Consul showed very elegant data showing that there are structural brain disruption in infants with congenital heart disease. Interestingly, few other studies showed functional brain alteration in this population. Using MRI and EEG, the group from Toronto found that brain injury and developmental disnaturation of white matter structures are associated with increased high frequency and decreased low frequency EEG connectivity, reflecting an inefficient synchronization of neural activity between brain regions. In 2018, the assist crews from the group of Catherine Limperopoulos compared all brain functional connectivity of resting state fMRI networks in healthy term newborn and neonates with CHD. They scanned them before they had the heart surgery, before their heart were repaired. So they found an intact global network topology, but reduced regional functional connectivity involving critical brain regions in newborns with CHD before their heart surgery. However, there are no results in infants after the surgery. So we don't know if these alterations in brain functional networks persist after the heart has been repaired. So a couple of years ago, we started a longitudinal study that aimed to study the integrity and functional brain connectivity after the cardiac repair in 4-month-old babies with CHD, and trying to identify markers using resting state functional brain connectivity acquired with NIRS at 4 months, predictive of age, sorry, there is a typo there, predicting neurodevelopmental delay measure at 24 and 42 months. So basically, we recruited babies at 4 months with CHD and sex and age matched healthy controls. All participants undergo a NIRS recording, including a 12 minutes of resting state during daytime sleep. At 24 months, they come back to the lab doing neurodevelopmental assessments using the Bayley scales. And finally, they come back again. We see them again at 42 months for a multidisciplinary developmental assessments, including neuropsych, language, speech assessment, and occupational therapy assessment. And they also undergo a second NIRS recording. So today I'll present the data we acquired so far at 4 and 24 months in these babies. And this project is led by two great PhD students, Salène Fourdin and Sarah Provost. So far, these are the participants. So far we have 31 controls, healthy controls, and 21 children with congenital heart disease that have been seen at 4 and 24 months of age. There was no difference in sex and age at testing, and at the gestational age, they were all term babies at the time of testing. However, there was a difference in maternal socioeconomic status between groups, which will be taken into account in our analysis. So for the functional connectivity NIRS recording at 4 months, we used 64 active channels, including 42 sources and 8 detectors. We placed them over 4 regions of interest, over the frontal, frontotemporal, temporal, and parietal areas, following the 1020 international system. We also added a short distance channel, allowing to regress physiological noise. So these are the results. These are connectivity matrices revealing phase coherence values between each NIRS channel. So this matrix is the average matrix, the sort of average phase coherence result from CHD group, and this one from the control group. Each matrix has is divided in 2 triangles, so these are mirror results. So the triangle at the bottom, this one here, is exactly the same than this one here, the upper triangle. Each matrix has, we look at data from the right hemisphere and left hemisphere. So here also on the top, and from the 4 region of interest. So in pink is temporal, parietal in green, frontotemporal in red, and the blue is frontal. So so that's it. So, oh yeah, the color bar. So for the warmer colors, like the red colors, show stronger occurrence, phase coherence between region, and the blue colors or colder colors show weaker connectivity. So if we look at the matrix if we compare them, if we compare the overall matrix between groups, we can see that they both exhibit similar spatial organization with strong functional connectivity in adjacent channels, as we can see here in the diagonal line, and in homologous bilateral regions. However, the overall connectivity strength in infant with CHD seems lower than healthy control. So basically, we can see here that the CHD matrix, it's a bit more bluish compared to control, showing a weaker connectivity. Another way to look at it is with this graph that shows the distribution of means of functional connectivity strength for both groups. So here on the x-axis, we have the connectivity strength, and this is a number of connections that are associated with each strength. The pink bars are the result from the CHD group, and the blue bars from the control group. And we have the red bar vertical line here, the mean for the CHD, and the blue vertical line, the mean for the control group. So basically, we can see that the distribution for the controls, the blue bars, is slightly right shifted due to stronger connectivity in this group compared to the CHD group. And when we compare mean, we have statistical difference between both groups. And if we look at the, we were wondering what are the connections that are different between both groups? So where are they in the brain, and how many connections are different? We can see that it's stronger for CHD compared to, for control compared to CHD, but we wanted to visualize it differently. So we use connectograms controlling for SES, here. So we have the data from the 4 regions of interest, again, frontal, frontotemporal, parietal, and temporal in the left hemisphere and the right hemisphere. These connectograms on the left show all connections between regions that are stronger for controls compared to CHD. And these are connections that are stronger for CHD compared to control. So we know that the connectivity is stronger for control. So we are expected to have more connection here. That's what we see here. So basically, overall, we have 142 connections that differ between groups, but it's 80% of the connection that are stronger in controls compared to CHD, and only about 20% of connections stronger in CHD compared to control. When we look at the distribution of these connections, we can see that the affected connection, or the connection that are different or weaker in the CHD, are half of them they are all over the cortex. So they are distributed all over the cortex, but half of them were interhemispheric connections. So connection between a region in the left and a region in the right hemisphere. We also found that the frontal region, connection involving frontal region account for approximately 35% of all group difference. So showing potential vulnerability of the frontal areas in CHD. Also, there were no differences found between groups when we compared intertemporal connectivity. So in both groups, the connectivity between temporal lobes was strong. So there was no difference there. However, I have to say that these connections do not survive the FDR corrections, probably due to the small sample size we have so far. These are preliminary data. Nevertheless, we cannot rule out that these differences are not false positive. So we need to increase the sample size. So to conclude on the 4-month data, we see that after cardiac repair, we find an intact global network topology in CHD as it was found by Diaz Cruz using fMRI before the corrective surgery. However, compared to LT control, infants with CHD exhibit a widespread reduction of functional brain connectivity, suggesting that functional alteration persists after cardiac surgery. And among altered connection in CHD, half of them are interhemispheric, which may reflect a brain immaturity, but we need to do more analysis on that. Also, about 1/3 of the reduced connection involve frontal region, suggesting a specific vulnerability of these regions, as we found in others found in other vulnerable populations. And there was no difference between group 4 homologous temporal region connections, which was also found by Diaz Cruz before the surgery. But now we want to know what's the relationship between the 4-month-old FNIRS results and the 24-month neurodevelopmental results. So that's what we find at 24 months. These are the neurodevelopmental results of both groups using the Bayley scale. So as my colleague said, the Bayley scale provided cognitive, language, and motor scores. The blue bars are the controls and red bars are results from the CHD group. So as we can see at 24 months, when we control for SES and sex, there is no difference between group for the cognitive and for the motor scores. However, the CHD group has significantly lower language abilities than controls. If we look more specifically at the language score, if we look at receptive and expressive language score, because the Bayley allowed us to divide this, we can see that the congenital heart disease babies have lower receptive and lower expressive language score compared to controls. But the goal of this study was to look at the relationship between 4-month-old and 4-month-old functional connectivity and 24-month neurodevelopmental outcome. So these circular graphs show significant positive association in red between the functional connectivity and neurodevelopmental outcome. And the blue circular graph show the negative association between functional connectivity at 4 months and 24-month neurodevelopmental outcomes. So in other words, if for these red connection are the measure at 4 months, the connection recorded at 4 months that positively correlates with the receptive language on this side, and this one that positively correlates with the expressive language, and the blue one are negative correlation. So it goes from -1 up to 1. So if we look at the connection at 4 months that correlate positively with the neurodevelopmental outcome at 24 months, we see a similar pattern between groups for receptive language involving many left hemisphere connection and frontal area, and interhemispheric connection, frontal area. This is for the receptive language. But for the expressive language, we can see that the number of connections is similar, but the topology is slightly different. So we need to deepen our analysis to better characterize these differences. But the main group difference is when we look at significant negative association between groups, negative association between resting state functional connectivity at 4 months and language outcomes. So we can see there is a clear larger amount of negative connection associated with in the CHD group compared to the controls in both the receptive and the expressive language. So these are preliminary results, as I told you. So we need to deepen these analyses to understand better, and all comments will be very welcome. So in sum, the longitudinal results show that compared to controls, 24 months with CHD exhibit poorer score in the language domain, in receptive and expressive languages, which is coherent with our previous work and with the literature. It could suggest that altered functional connectivity in infancy is linked with poorer language outcomes. And when we look at more specifically at this relationship, we see that a diffuse pattern of connections seems to be associated with 24-month outcome, included short and long distance connection, as well as intra and interhemispheric connection. So it's quite diffuse. And when we look at the group differences, we see a larger amount of connection involved in positive associations between functional connectivity and language outcomes for healthy controls, whereas an opposite pattern occurs in children with CHD. So we believe that this large amount and very diffuse pattern of negative association may constitute a predictive marker for neurodevelopmental outcome in children with CHD. So, but we're not there yet. Now we need to better explore the brain network topological properties in both groups and their association with the neurodevelopment using other approach. For example, we're applying now a various graph theory matrix, hoping that will help us to better understand the differences we see at 4 months, because we see a lot of connection, but we need to better understand the topology of that and the organization of the networks. And finally, we are pursuing data acquisition at all time points, starting to analyze also data at 42 months, the functional connectivity nears and the behavioral data at 42 months, since some kids just reached that age a few months ago. So we need to look at developmental, brain, and behavioral trajectories. Hopefully, this project will contribute one day to refine and individualize early intervention in children with CHD. So thank you for your attention. And this is the main person who worked on the project in the lab, and collaborators from the clinic, from Cuba and from China. Thank you.
Thank you very much, Anne. Some of the other colleagues, do you want to make some observations?
If I may, thank you.
Okay.
If I may, and that was a very elegant talk. Thank you very much. I really enjoyed it. I've got lots of questions actually, but I know we don't have a huge amount of time. So I think perhaps the one that perhaps the most general one is, how do you interpret the negative functional connectivity? What do you think that actually means?
Yeah, it's a really good question. You mean the fact that there are the strength is lower, or the fact that there is negative association?
Sorry, a negative association, yes.
Yeah, I have to say, I'm not sure. We discussed a lot about it in the team, and at the beginning, we thought it was maybe a way to, how do you say that? A way to an adaptive way, because the scores were not that lower. There were not that many difference between group for neurodevelopmental data. So we were okay. There is negative association, but they are not bad. They are still good. But then we increased the sample size, and now it's pretty stable. And now we have this big difference for language scores. And I'm really not sure. That's why we are doing some analysis, because we want to better understand what the organization of these connection, of these altered connection. Maybe that will give us some answers to interpret the data, because at this point everybody's taking different things. So I don't have a straight answer. Do you have any suggestion or hypothesis?
No, I don't. I genuinely don't. So that was very, very interesting, and yeah, it's quite intriguing. So yes, thank you. I'm not sure if is there time for more questions, Dr. Harmony, or should I?
Yes, of course.
Well, one other thing, and that's really nice about your data, is that it's post-surgical. And so do you think you could use this to look at surgical risk factors if you've got functional connectivity after surgery? Do you have a homogeneous sample, or do you have different CHD with different surgery types? Because it might be quite interesting to see any relationships between the surgical procedure or the perisurgical time points and their functional connectivity.
Yeah, it's a very good question, and we would love to do that, because in our center we have a lot of TGV, transposition of retinal, but we don't have a lot of hypoplastic left heart syndrome, and I think the Toronto group has the opposite pattern, and it might be because what the doctor said, the cardiologist said before, at the time of diagnosis. So some people decide to interrupt the pregnancy, and so we really want to dig into that. But now, as you saw, we just have 21 kids, so more than half of them are TGV, but we don't have enough power to look at this for the moment. But because for the moment there is nothing can come out significant regarding the type of surgery and the severity of the disease. Severity is very similar in the whole group. So
thank you. Thank you.
Well, thank you very much, Anne, and we will come to the last one that I will present. So please, well, I will present to you the early detection and treatment of attention deficits in preterm and at-term infants with risk factors for brain damage. Preterm and term infants with risk factors of perinatal brain damage show very frequently deficits in memory, attention, processing speed, and executive function. And for this cause, we have studied attention. Attention is the ability of a child or infant to orient to, shift between, and maintain the focus of the object, task, and problems in the external world. The orienting system, consisting of a spatial orienting network in the parietal cortex and an object recognition pathway in the temporal cortex, becomes fully functional during the first months of life and is related to the orientation of movement of attention toward specific locations in the environment. Deficits in early orienting and sustained attention are predictive of later attentional, cognitive, and behavioral functioning in children born preterm. Similarly, attention deficits in preterm infants have been related to outcomes of attention deficit hyperactivity disorder. The studies indicating that early attention deficits may evolve in this syndrome provide a rationale for the detection and treatment for infant deficits. We focus on the orienting response to different visual and auditory stimuli in preterm infants in the present study. We present the characteristics of a battery for the selective evaluation and treatment of infants with the attention deficits and the obtained results. What we have been using is the infant scale of selective attention. This is an instrument that assesses the development of a process in infants from 1 to 8 months of age. It is divided in 2 subscales, visual and auditory. This battery measures an infant ability to select both visual, for example, cars, mirrors, rings, cubes, and balls, and auditory stimuli, for example, voice, bell, rattle. Infant responses are orienting to the target assessed behavioral by localized eye-head turning. Here we have the pictures of a child looking to the object that the researcher presents, and we see that it has a very good response. This is the visual. But also, if the infant is not able to do adequately at this scale of selective attention, we have the early attention stimulation program. That is a treatment based on the notion that the strengthening the neurocognitive networks underlying will reduce attention deficits, preventing it from becoming a well-established attention disorder. This treatment procedures analogous to the procedures that we evaluate. We taught the parents to perform in-home treatment at least twice a day. In this early stimulation attention behavioral treatment, the duration are 30 sessions, twice per week in the laboratory and remaining days at home. Each session lasts 20 minutes. Attention was evaluated each month from the 3rd to the 8th month of age. Here we have the participants. The participants were 62 infants that we divide into groups. A control group that have a good performance in the infant scale of selective attention, and another group who show very low standard values and therefore were treated. This with the treatment we have described. So we have control and treated subjects. In this graph, you can look at the distribution of females. It is larger in the treated group. And we have divided the groups of children according to the World Health Organization in very preterm, moderate preterm, late preterm, and term infants. And you can see here what is the distribution of the children of the control and treated in each one of the groups. All these children had prenatal and perinatal risk factors. Many of them were very frequent. Children may have more than one factor. And we have here the control and the treated. And as you can see here, there are some risk factors as infections in the mother that are extremely frequent in both groups. Another thing that is very frequent is fetal distress, sepsis, and once the child is born, the respiratory distress. All these children have great risk factors, and this is what we have to emphasize because there were no normal children. Here, I may show you the main MRI findings. The main MRI findings were an increase in the subarachnoidal space. And we can see this in this MRI, in which the orange arrows are indicating the great space between the bones and the cerebral cortex. The other very frequent were the diffuse brain abnormality. This can be observed in here, for example, looking for the white arrows here. And also in here, for example, we have small hemorrhages and great porencephalic cysts, as we have here, because this is these are the MRIs of an infant of 3 months of correct age that was born at 30 weeks. And he present a bilateral germinal matrix hemorrhage intraventricular. So you can see here the hemorrhage and a large enlargement of the lateral ventricles. You can see that this is also very frequent. In this infant, he was also born at 30 weeks of gestation, and we can see what I have said, that an increase in the volume of the subarachnoidal space and the diffuse white matter abnormalities. In the other, we may see a great, well, it's I think it's not possible to see, but I will try to move. You can see in this angiography that the left middle cerebral artery is occluded. And for this reason, it has a great lesion in the left hemisphere. So children have only the treated group have only the control group have 2 children with normal findings. In the treated group, there were no normal findings in any children. In the next, these are the results of the application of the Bailey-III at 4 months of age. And you, in the 4 groups, very preterm, moderate, late, preterm, and term. You can see that they are very similar in both control and treated group. Here in very preterm, it appears as if the control have higher values, but as the number of subjects was not enough, there were not significant differences. So they have adequate values for the Bailey scores in cognition, language, motor, social, emotional, and adaptive. In this, I don't know if you look only at the green square or you are looking at the whole picture. Please tell me.
I think the whole picture.
You're seeing the whole picture, okay. These are...
It seems to be a zoom on my side.
I don't know why this is a green square. Well, the raw values of the infant scale of selective attention during treatment, we can see here. Treatment was from 3 months to 8 months. And we have a treatment of visual, in which, if you see, there are at the beginning significant differences in the performance of this task. Both at 6 months, there were no significant differences, and at 7 and 8, they have the same values. So This indicates that the success of the treatment and the visual evaluation, the visual stimulation. On the auditory, you can see also here the raw values of the performance in the infant scale of selective attention from 3 to 8 months. And you see that in this auditory evaluation, treatment at 3, 4, 5, and 6 months have different mean values, the control and treated. But at 7 and 8 months, they were the same. So in this graph, we can see that the treated group slow approach the values of the control group, and these results indicates the success of the treatment. Another study was a study with event-related potentials. The experimental design created 3 groups of children. In one group, we have a clinical examination, the MRI, the visual evoked potentials, and the brainstem auditory evoked responses, and the attention scale normal. And this is the normal healthy group. When they have problems, they have not normal in everything, we see that they were preterm, that they have an abnormal MRI, they have normal visual and auditory evoked responses, but deficit attention. This group of preterm babies were divided in 2 groups, a control group in which we did not give treatment, and an experimental group in which we give the treatment. Here is the type of stimulation we give. We use an oddball paradigm on which 80% were tones of 1000 hertz and 20% of 1300 hertz. The stimuli was duration 255 milliseconds with weak intensity, and the interval between the stimuli were 500 milliseconds, and between interval trial, it was 2 seconds. Children were asleep during the recording. Here are the children, the electrodes, and these are the auditory stimulation. Here we have the event-related potentials. First, at 3 months before treatment. And we have in the healthy, the control and the experimental group. At 3 months, we can see that in black is the response to the standard stimuli. In red is the response to the deviant stimuli. We can see that in the healthy group, children had a very good response to the deviant stimuli. Also, the control and experimental group at 3 months have this difference between the deviant and the standard responses at 3 months, the control and experimental. However, the amplitude was lower than the observed in the healthy group. However, at 8 months, what we see was the following. This is the healthy group, continuous with a beautiful response of P3A. And this is the control group that was not treated. And what we may observe is that there are no differences between the standard stimuli and the deviant stimuli. However, in the experimental group, we observe a very different thing. The standard is in black and the deviant is in red. And in the experimental group that has also the lesions, and what we found was a very large negative wave that we consider it was an NC response. This was very, very important because we were not able to see the mitochondria, but we see the NC. In conclusions, we can say that the specific visual or auditory-oriented response may be evaluated from 3 months old with a scale of selective attention, and we recommend this test. If deficits in the infant performance are observed, it is highly recommended to begin to treat the child with the early attention stimulation program. 2 groups of preterm infants with attention deficits were studied, and treatment with the early stimulation program was only given to 1 group. The treated group improved behavior, and at 7 months, they have a normal performance. At the beginning of the treatment, at 3 months old, the event-related potential to infant stimuli were similar in these 2 groups and with a smaller amplitude than the response of the normal term infants. At 8 months of age, the non-treated group showed no difference between the standard and the deviant stimuli, which suggests that the brain lesions observed have evolved. At 8 months, the treated group showed an NC wave. Meanwhile, the healthy group continued showing a P3. We have to discuss this finding. Preterm infants that were studied have prenatal and perinatal risk factors and abnormal MRI findings, but we suppose that maybe these infants have such damage that were unable to produce EP3, but their brains reorganized by the treatment produce an NC. We believe that during development, the NC component appeared earlier than the P3. It's maybe that for preterm treated babies, NC networks were more mature than those from P3A. And then this was the explanation for seeing this reorganization of the brain in the treated children. Thank you very much. I don't know if you have some questions or observations.
I might have missed this information, but I have a methodological question. It's when you showed that in the last study, the group of preterm, some of them received the early stimulation treatment, and the other one did not receive it. How did you allocate babies in each group? How did you divide the groups?
Well, because it was at random, because we have not tried the stimulation program, even in that time. So we want to prove it. And so we made a random selection. I present after we have shown the results of the treatment. But in this occasion, the event-related potentials were recorded before we suppose what made the treatment. Mm-hmm. And therefore, we were able to have a group without treatment. Now I am not able to repeat the experiment because I know the treatment is very good, and then I will give treatment for everyone. But in that occasion, we have to prove what was going to do the treatment. And for this reason, we divide this in at random, the groups.
And did you look at if there was differences between groups on clinical variables or on SES, socioeconomic status between groups? Or I guess since it's random, there were no much difference, but did you look at this?
Well, you know, it's as I said, every infant has many risk factors. So we cannot select very clearly what the factors will be in one group and in the other, because it is very, very difficult to try to match the groups.
Mhm.
I have tried to match groups in another question, but I always match groups not by the risk factors, but by the MRI. But in this case, the MRI was worst in the group of treated.
Oh, really? Wow. Okay.
So I think it's okay what we have done.
It's very interesting, impressive work. Thank you.
Well, I think the test that we have that we are talking about, it is very important. And Serena, I will recommend it to you, because attention is one thing that is not really very well studied with the Bailey 3. And this special attention program, we can try for Juan and to you, Serena, to bring it in English, to see if we are able to give you this in English. Maybe you can begin to use it, not only the evaluation, but also the treatment. There are many, many preterm infants with attention deficits.
Thank you, Dr. Harmony. Yes, I shall pass this on to my clinical colleagues. Thank you.
Yes.
Is there a version in English already?
No.
Okay.
But, we will do. I will do it with Monica. I think because we work in both. We will both work in this thing, and I think if we have it in English, it will be okay. Because the things that are needed, for example, cars, it's very simple. You have very different type of cars or pictures, and the auditory is also very simple. It's voice or rattle or something. So it is a bell. We use a bell for the auditory also. So it is very, very easy. And if you teach the parents to give the stimulation, it is also very easy for them. And it is important to teach the parents. We are following these children because we want to know if the treated group will show the deficit in attention with hyperactivity. That's what we want, because if with this treatment we can destroy the pathways that are going to give the syndrome of attention deficit. It will be a very important thing, and we are following these children. So we have now some children that have an age of 3 or 4 years, but we may have to continue to see what happens with it.
Doctor, we have a version in English in the article we published, a first version in English. So we need to maybe improve the complete version, but we have a version in English in a published article. I can send you one, or Dr. Ferreira, if you are interested, I can send the article in which there is a first version of the program.
Thank you.
Well, I think we have finished. If someone has something to say, please do it, because we have 5 minutes more.
I would like to thank you, Dr. Harmony, for organizing this session and bringing together very different topics, but that are all related to cognitive outcome in these at-risk children. So thank you very much for inviting me to join this very interesting session.
Well, thank you to you, Serena, because I learned very much from your research, and I will do these multimodal comparisons. It's possible to do it.